Good morning, everybody. Happy Friday. Welcome to the Department of Biomedical Informatics and Data Science PowerTalks seminar series. I am very happy to introduce today's speaker. I've known him for a while, and we have a lot of connections going back. Dr. Adam Wright. He is Professor of Biomedical Informatics and Medicine at Vanderbilt University Medical Center. He also serves as the Director of the Vanderbilt Clinical Informatics Center, VCLIC. He has been extremely active, leading NIH, AHRQ, ONC-funded projects. His focus areas have been on clinical problem list, malfunctions, and clinical decision support. Imagine that. Sharing clinical decision support nationally and detecting adverse events using machine learning. He has over 130 peer-reviewed journal publications and 100 additional publications. He's very committed to teaching. He's directed and lectured on the local, national, international level, courses in informatics and teaching medical students. He directs clinical decision support operations at Vanderbilt University Medical Center. Previously, he was lead for clinical decision support and clinical informatics at Partners Healthcare in Boston. He's also active in our national and international in service, serving on the board of the American Medical Informatics Association, AMIA, an associate editor for Clyde Clinical Informatics, and an editorial board member for Methods of Information Medicine and the Journal of the American Medical Informatics Association. He's the founding and director and member of research for Clinical Informatics Research Collaborative. He's received numerous awards. I don't want to go into all of them, but he's also been elected to the American College of Medical Informatics and has many other, and also education, we have shared connection through OHSU, and he's very well recognized, and I'm very happy to have him present this very interesting topic, clinical informatics research and innovation in the age of commercial EHR.
Thank you, Amy. I really appreciate that. I'm super excited to be talking to you guys. I'm a big fan of UAB and what you guys have done and are doing, and have a lot of good collaborators there. Some of which I see out there in the room or on the participants list. So thank you guys all for coming. I also want to apologize for not being there in person. We just had a newish baby, and so I'm still not able to travel that much yet, but I told Amy that if I ever get invited back, I will definitely come down and make the drive to see you guys in person, because I think that would be a lot of fun. So as she said, I'm going to give you guys this talk that I've been working on for you guys called Clinical Informatics Research and Innovation in the Age of the Commercial EHR. And I think you guys will relate to it very well. And one of my goals here is just tell you about some of the stuff we're doing at Vanderbilt and things that I think you guys could consider doing, and then especially I hope to maybe lay the groundwork for some additional collaboration. I think we obviously have some geographic proximity, mutual interests in decision support and data science using our electronic health record, and just generally trying to make the computer smart. And so I really hope that we can use this almost as the springboard to think about ways that Vanderbilt and UAB could be collaborating more. So feel free to interrupt me by shouting or typing in the chat or the Q&A. I'll do my best to monitor those as I go here. But my talk sort of starts with a little bit of history. It doesn't go quite this far back. This is Medical Center North, the first set of buildings at Vanderbilt's Medical School and Hospital that still stands. We've added a lot to it. It's really easy to get lost in the sort of maze of hallways here. But instead of going back this far, I will go back to the early 1990s when Vanderbilt got a grant, an IAMS grant, to implement an electronic health record. And what was interesting was, now everyone has an EHR, but at the time it was a novel enough idea that you could actually get a grant from NLM basically to implement an EHR. And so Bill Stead was the creator of this, and he's retired. He's retired, but he's not retired very well. I see him in the office more than I see a lot of people, but he sort of laid out this strategy and still works here at Vanderbilt. But his vision was sort of a centralized communication management system with a bunch of spokes like radiology, laboratory, and pharmacy systems and EHR. And I think one of the most interesting things in his vision was B here, what he called global knowledge. But he had this idea that we would actually take knowledge, in this case from the medical library, and sort of embed it deeply in our electronic health record and use it to drive high-quality evidence-based care. And even though we now use Epic, I think some of this vision still kind of plays out. So in the years that we had a self-developed EHR, we did a lot of interesting research. So this is our star panel system where we can view patient data and write notes. This is WizOrder, which we used for order entry. And one of the cool things about having a self-developed EHR is that you have the source code. So if we wanted to change the way that you ordered gentamicin or other antibiotics, you would check out the ordering module and you would edit the Java code and check it back in and release it. And so we developed a lot of, I think, kind of bespoke decision support tools. So this one takes some patient information and then asks you about the indication for giving gent, and then shows you the patient's relevant data, in this case, especially their creatinine, which is elevated, and the fact they have myasthenia gravis. And then if you decide to proceed, helps you sort of dose the medication and order appropriate consults or drug level monitoring to follow up on that. There's a bunch of other buttons like how show me the calculations, or I want to do once daily dosing instead of more frequent dosing, or actually, sorry, less frequent dosing. But it was really cool, right? So we can sort of just check this out and make it however we wanted. We used it to do pharmacogenomics. So for a long time, we take a lot of our patients and do this panel that we call Predict, which is a sort of SNP panel for a lot of the most common drug metabolism, kind of CYP2, C19, I guess, kind of genotypes, and then look to see, kind of within the cytochrome P450 system, like whether there are any modifications that we should use different medications. And so this patient has a CYP2C19 variant, which makes them a poor metabolizer of clopidogrel. And so they are at increased risk of stent thrombosis if we give them clopidogrel, but we can give them prasugrel instead. And we suggest that. And so again, we built this decision support tool in our legacy system, and we had complete capacity to sort of configure that however we wanted. So that led to a lot of papers. So a lot of the work that we've done in publishing at Vanderbilt here to up to date was on our legacy self-developed EHR. And then sort of, there's kind of this dun-dun-dun moment, something happened. And so the something that happened was we switched from a self-developed system to Epic. And it was a large big bang rollout. It happened in 2017. So it's funny, it feels like it was really recent, but it actually was now almost six, almost coming on 7 years ago. And it was at the time the biggest Epic go live that had ever happened, and we did it all at once. And we were not alone in this transition. So if you look back towards the beginning of my career, many of the leading academic informatics sites had self-developed EHRs, and today all of those sites have either switched or are in the process of switching to an EHR. In most cases, Epic, occasionally Cerner. In the specific case of Intermountain, they switched from their self-developed help system to Help 2 to Cerner, and they're now switching to Epic. So they've had quite a few hops on this journey, but it is increasingly uncommon for sites to develop their own EHR, and increasingly common for sites to use a commercial EHR. And in most cases, that site is that EHR is going to be Epic. So some of you guys, if you've been around for a little while, remember the days of low EHR adoption. So back towards the beginning of my career, less than 20% of doctors and hospitals used an EHR. Now, for hospitals, close to 100%, and for doctors' offices, about 80% of people are using a certified electronic health record. And again, in terms of market share, we see that Epic has the dominant position, and their lead seems to be growing. So other systems are going down a little bit, and Epic, it continues to increase. So we sort of entered this universe where no one had EHRs, then some special people had self-developed EHRs, and now everyone has a commercial EHR, and most frequently that's Epic. So what is good or bad about that? So there's some downsides. When we got Epic, we were really worried if there would be limits to how much we could innovate in the system. I told you guys that we wanted to implement the gentamicin dosing advisor. We just checked out the source code and edited it and then checked it back in, and we were done. And so there were no limits to what we could accomplish. I would say we've been pleasantly surprised. We have all been learning a lot about Epic and what its internal capabilities are, how it can be extended. I'll show you guys over the course of this talk a lot of ways that you can extend it, but I think we've been pleasantly surprised about that. There were some questions about IP. If we made something cool, could we publish about it? Could we sell it or start a company or something? We've been kind of favorably impressed with kind of the outcomes of this. We've never been slowed down from publishing things or sharing things in an open source fashion. There are some questions if we wanted to start a company to sell things, whether Epic would want a cut of that or how we would sort of let that play out. And my solution has just been to make our stuff freely available. You know, I get NIH grants, and I'm pretty happy with that business model. But you can imagine if you wanted to start a company, it might be a little bit more complicated. And then for a time, Epic was giving us a hard time about screenshots. We had to get permission to share screenshots. That's no longer the case. The 21st Century Cures Act had some information blocking provisions, and one of the more esoteric information blocking provisions actually prohibited companies like Epic from limiting our ability to do demos or share screenshots. So we've been able to do that. So those are the downsides or the challenges. And so there are some good things about this too. We were spending more and more of our time trying to meet government regulations and keep our EHR certified by the government so that we could use it as part of the Federal Meaningful Use Program, and that made it hard for us to innovate. And so now Epic can spread the cost of certification and regulation compliance across hundreds of customers rather than just Vanderbilt sort of paying on our own to meet these needs, which means that our researchers are freed up to do research, our innovators are focused on innovation, and our software developers can develop the stuff that we want to develop, not just the stuff that the government is sort of making us develop. We also had this situation where every paper we would write, we'd send it to Jamie, and we'd get this comment back, sort of like, look at you in your ivory tower with your self-developed EHR. Can someone else do this? And we didn't have a great answer for that, but now we can sort of say, well, actually, look, we're using Epic. More than half the beds in hospitals in the United States are covered by Epic. So if we show that you can improve this thing X in Epic, then maybe it's generalizable to other people. So I think that the work we do is now more representative, and I think we get less trouble now from from Jamie reviewers about that. But also say it's easier to disseminate these things. So, I spend a lot of my time at AMIA and the CIC conference and writing papers in JAMIA. But I also spend some time at Epic's meetings, XGM and UGM, sort of sharing the things that we've built. And at least when it comes to sharing with other Epic customers, it's actually quite straightforward for us to share the content we develop with other Epic customers, and where we use standards-based tools like Fire, Smart on Fire, CS6, it's then easier to share with everybody, not just that. So I'd say that our representativeness and dissemination have increased. At the same time, I think there are still people at Vanderbilt, especially early on, and maybe still today, who say like, oh no, everything got jammed up once we got Epic. It's been a lot harder to do things. And so I came up with this talk, partly for you guys and partly for my friends at Vanderbilt, to try to motivate or explain what you should do if you want to innovate in or around your EHR and you find yourself in a situation like you guys are and like we are, where you have a commercial EHR like Epic. And so think of it as a choose your own adventure. I've got two options here. Option one is going to be embrace your EHR, and option two, I'll just forecast, is going to be kind of building on your EHR as a platform. So this is our Epic EHR, and you can log into it. And people often think that this whole thing comes from the good people in Verona, Wisconsin. The reality is that when Epic sells you an EHR, it's largely an empty shell. And so everything that is in here, we configured ourselves. And so this is the schedule here, and all of the columns you see, we chose what would be in those columns and how they would look and how they'd be colored. We decided that we wanted to focus on disease management, flu shots, other immunizations, whether outside records are available. So we controlled what columns are visible on this screen. We controlled how the messages sort of show up along the side. When you come into the plan tab or the synopsis tab, you see information grouped a certain way by organ system. In this case, we chose to group it by organ system. We build these best practice advisories. So in this case, the patient might be due for AAA screening. And so we put this here. We decided AAA screening is important to us. And so we built this best practice advisory. When it comes to documentation, we build the note templates, and we build different templates for different departments and different situations. Users can customize their templates, but these are things that come from us rather than come from Epic. So that is our experience with sort of building documentation templates. We build order sets ourselves, and so we have our own sense of something like pneumonia, sort of the best ways to treat pneumonia and the right antibiotics to use. And so we have developed an order set that guides people. We did some research here, a trial where we concluded that we liked using lactated ringer solution and Normasol more than we liked using normal saline. And so we took that lesson, which we developed here and published, and we changed all of our order sets to encourage use of these balanced crystalloid solutions as opposed to normal saline for our patients. We also help people pick out the right antibiotics. So we told the Epic that this patient is not pregnant, not in the ICU, and doesn't have risk of Pseudomonas, doesn't have any allergies that we know of. And so it says that perhaps the best antibiotic choice for this patient is an oral fluoroquinolone like levofloxacin. But if we'd answered the questions differently, we would have gotten different advice. And if we, as our antibiogram shifts over time, we have made adjustments to this order set. So we make that ourselves. We get requests from users, so we do some hemodynamic calculations. And our cardiologists were saying, I keep pulling out my phone and doing this FIC. My phone doesn't want to show up there. Doing this FIC calculation, and could we build this into Epic? And so one of our internal medicine physician builders built a cardiac output and cardiac index fixed score calculator that uses data and sort of shows its work and shows its formula. Again, we built this. We didn't need to get it from Epic, although Epic then gave us the ability to share that with other Epic customers. Similarly, we've been interested in increasing prescriptions of statins, and so we built an ASCVD risk calculator and then a BPA that helped organize to suggest ordering statins were appropriate for patients, and we're doing a randomized trial of this. So we build a lot of sort of studies and evaluations into the work we do. And again, this didn't come from Epic Verona. This came from people at Vanderbilt. And one of the things I think is special about what we've managed to accomplish so far at Vanderbilt is a lot of what I've shown you actually was built by doctors, nurses, and pharmacists in our clinics and in our hospital, working in collaboration with health IT staff. So we have a very decentralized approach to building and studying these things. But this was built by a primary care doctor who wanted to increase the use of statins in her clinic. I also built something that encourages naloxone prescription. So I know you guys have challenges with opioid overdose, and so do we here in Tennessee. And so we use a very simple risk model to identify patients that are at high risk for unintentional opioid overdose. And then we suggest prescribing naloxone or Narcan, if you guys have ever heard of Narcan, which is a life-saving medication that can sort of quickly reverse an opioid overdose. And we were not prescribed enough of it. And so now we detect patients, we explain why we think they're at risk of opioid overdose, and they give the option to order naloxone or the injectable FZO form of naloxone for those patients. We had a dramatic increase in the rate at which we prescribed these things after we turned the alert on. So in the middle here, we had done like this educational intervention where we told people they should prescribe naloxone. You can see we had a very small uptick in the rate at which we were prescribing naloxone, and then we turned this alert on, and then we had a much higher rate of prescribing naloxone that seems to have persevered over a fairly long amount of time. We've actually now had the chance to talk to some patients who have used the naloxone. In some cases, it was used on them by a loved one. In many cases, actually, we prescribed it to them, but they used it on a roommate or family member or stranger that they saw. And so we believe that some people in the Middle Tennessee area are alive today because this alert encouraged their doctor to prescribe naloxone. And again, it wasn't Epic that made it. It was a pharmacist working with an addiction medicine doctor and an emergency doctor and me in our informatics center to build this out based on a goal that we had established to improve naloxone prescribing. We can also use this for safety promotion. So we had a situation where somebody was trying to order apixaban, which is one of these direct oral anticoagulants, to treat a patient's pulmonary embolism, and that requires a higher dose than the more common use of this medication, which is for stroke prophylaxis in patients with atrial fibrillation, but accidentally ordered the wrong sort of lower dose. And so we rebuilt the apixaban orderable so that we ask you what the indication is and we help you dose it appropriately. based on what the indication is. We also help you order appropriate labs and follow-ups. So it's kind of similar in spirit to the gentamicin dosing advisor that I showed you guys previously, although it is now built using Epic's tools rather than just checking out the Java source code and rebuilding it. So it's maybe a little bit less customizable, but it's also quite a bit easier to build, especially for clinicians. So if you decide that this sounds fun and you want to engage in this kind of work yourself, first off, you can. So you could use your credentials to go to userweb.epic.com and see Epic's documentation. This is a website where you can sort of chat with people, see upcoming Epic webinars, access Epic's documentation library. So the whole manual for the software is there. You could also view videos at welearning.epic.com. So I told you guys I'm personally interested in decision support. So if you want to learn about Epic's decision support capabilities, you can search up the word decision support on the website and then get these results and watch them. So if you were, for example, preparing a grant application, or if you wanted to, for quality improvement purposes, propose the creation of some new decision support, watch these videos and sort of learn about what is involved in doing decision support using the Epic system. If you want to go a step further, Epic offers trainings for their system. You can actually become certified. So you could, if you're a physician, there's a physician builder training program. If you're not a physician, there's a clinical content builder or research training. If you want to access Epic's data warehouse, there are trainings for Epic's Clarity and computable data warehouses. And so we have quite a few people. In fact, currently 88 people at Vanderbilt that are in our physician builder program. So these are sort of kind of normal clinicians. We call them physician builders, but there's actually nurses, pharmacists, and Ph.D. informaticians in the program too, throughout our hospital, primarily not based in or funded by our health IT department, but instead funded by their own clinical departments. And they are deputized to build some of the kinds of things like the ones that I just showed you. And I think this decentralization has been really, really helpful to us as we've done this. And I guess we're also putting in a plug, we have some residents and fellows and medical students that have done this too, and they've been some of our most productive builders. So you can become a builder, whether you're a physician or not. I told you guys that in addition to the CIC conference in May, I'm going to be at Epic's XGM meeting. That's they call it the expert group meeting. And then there's another conference in August or September called the UGM, or the users group meeting. But basically once or twice a year, we go to Verona, we hang out with other Epic customers, we give feedback on development, we give our own talks about the things we've been building and try to convince other Epic customers that they should do the same thing to improve quality at their organization. So you can basically sort of embrace Epic and become the best Epic using, Epic building, applied clinical informatician that you can be. Some people want to do that. That's what I decided to do. I guess we're among friends here, so I'll tell you guys that I actually voted against getting Epic. I thought it would be better to continue developing our own EHR, but as soon as the decision was made to switch to Epic, I decided that I was going to get every training I could and learn as much as I possibly could about Epic and kind of become the best Epic informatics guy that I could. If you don't want to do that, if you sort of feel more principled and don't want to be sort of tied into a single vendor, you can sort of build on your EHR like Epic, as sort of a platform. And so there are a number of open, kind of non-proprietary standards and APIs. Probably foremost among those are Fire and Smart on Fire that let us embed applications in our Epic EHR. So this is an app we made at Vanderbilt that helps you. It's a very simple app. Just send pager messages to people, and it pre-fills the patient's medical record number and their initials and the name of the sender, and lets you kind of write a message while you're in the record. And this is a web app, a HTML web app that we built sort of outside of Epic, but it's kind of embedded deeply in a tab in Epic here. It fills in some contextual information about the patient. Working at Vanderbilt, so everything at Vanderbilt has to do with REDCap, and so we built some REDCap integration. We've now built a couple dozen sort of Smart on Fire applications that integrate with our EHR, and so you can learn more about the SMART standard and the related FHIR standard that together make up Smart on FHIR by going to the SMART website. There's an app gallery that shows a lot of these applications. Some of them are free, some of them are for sale, but they can integrate theoretically with any EHR, although, to be honest with you, I found that we've often had to do some localization or tailoring of our Smart on FHIR applications when we developed Epic and want to deploy it in Cerner or something like that. One thing that we've been having a lot of fun with recently is a voice assistant for our Epic EHR that we built as a Smart on FHIR application. So Dr. Yaku McChrystal from Vanderbilt has been leading development on that activity, but that's been pretty cool too. So Smart on FHIR is one standard. Another one is CDS hooks. You guys probably noticed that a lot of my research surrounds decision support, and we build an Epic, what we call best practice advisories. But CDS hooks is an open standard that lets you sort of register and say, when someone orders a medication, for example, metoprolol, call my web service and I'll tell you whether you need to pop up an alert or something like that. And so that standard is also supported for the most part by Epic. There's a number of different cards or sort of sections of the CDS hooks. I think Epic pretty much supports all of them, or almost all of them at this point. You can read about Epic's support for open standards by going to open.epic.com. And so you can view this site, look at some documentation. There's some Smart on FHIR and other sandboxes you can use to test these out. And then, you could work with your IT team, or at Vanderbilt, we'd work with our IT team to do these integrations. So those are open Epic APIs. Sometimes you get a situation where there are not open APIs that do what you want, but Epic also has proprietary APIs that let you do more stuff that there aren't currently Smart on FHIR profiles for. So we are resources. So we often build things in Epic. The name of this program has changed several times. It's been the App Orchard, the App Gallery, the Developer Program. But you basically sign up, and you could then use not just the open public resources, but also these proprietary resources. So you can read more about that at apporchard.epic.com. Epic is not alone in having these kinds of programs. So Cerner has the Cerner Code program. Allscripts has their developer program. Athena Health has a program like this. Meditech has some RESTful APIs. NextGen has the NextGen Healthcare Developer Program. Greenway has a API program for developers. And in fact, there are so many of these APIs out there for different vendors that now companies have sprouted up to basically create like routers or kind of things that standardize the API. So it's like an API on top of the API. So Datica is one of them. Redox is another one, but these are, companies you can work with to kind of call their APIs, which then translate to these other APIs. And so again, option one, sort of embrace Epic, become the best Epic using informatician you can. Option two, say, I'm not going to do all this Epic stuff, but I am going to learn how to build Smart on FHIR apps and CDS hooks and sort of engage with my EHR in that way. And so we knew these options existed, but we still sort of heard grumbling in the hallways about Vanderbilt about how I used to be able to do stuff. There was this one programmer named Dario who worked here, and the solution to most problems in the past was you bumped into Dario and you said, hey Dario, can you send me some data, or can you build out this thing for me? And then by the time you go back to your desk, there was a good chance Dario had sent you the thing that you needed. And now that wasn't the solution. And so we realized we needed some vehicle to make it easier to facilitate research and innovation here at Vanderbilt. And so that led to the creation of the Vanderbilt Clinical Informatics Center, or VCLIC. So you've got your left click, your right click, and your VCLIC. So we have a logo and a group of people. I'm the director of that center, and I'm proud that we have members in our center from essentially every department, clinical department at Vanderbilt. So these are clinicians and researchers across the medical center who are devoted to or dedicated to or interested in using the electronic health record to make care better at Vanderbilt. And some of them, I think, would identify as informaticians and spend a lot of their time doing informatics interestingly, a lot of them would say, like, I'm a cardiologist, and I just so happens that I'm interested in using data from our electronic health record or building interventions in the electronic health record to accomplish my goals. And so I actually think that an organization like UAB, probably like Vanderbilt, has a reasonable number of latent informaticians. These are people who may not have heard the phrase biomedical informatics, or may have maybe they are doctors now, but they were CS majors in college, or they worked as a software developer before they went to med school or something like that. You guys should find them and embrace them, because they can make some really outstanding colleagues and friends of your informatics program and now informatics department. And so our center has a bunch of goals, but I'll focus on the first one, which is just that I want people at Vanderbilt, so faculty, staff, and students, both people kind of in our core Department of Biomedical Informatics and across all of our clinical departments, to find it easy to access data, test innovations, and evaluate results. So I want somebody to say, if I want to improve the way we do screening for breast cancer at Vanderbilt, I'll be able to easily get the data I need to understand the state of the problem and possible solutions. And then I will be able to think of an intervention and test it out and see if it worked. And so, recently we noticed that I guess what we noticed was that people weren't going to use as many mammograms as we wanted them to. And so we sort of looked at the data and we realized that we're doing a good job of reaching English and Spanish speaking patients, but we have a sizable number of Arabic speaking patients, and we weren't doing a very good job of getting them mammograms. And so we made some changes by adding, more Arabic language resources and abilities to schedule things for Arabic speakers. And so we then were able to get some data and show that increased the uptake of mammograms in that group. And so we want people to not feel a lot of friction. Before we had VCLIC, sometimes you'd ask for data and people tell, well, we can get that for you, it'll take 2 years. We want to instead say, here's your data, or I'll have by tomorrow, or something like that. So that's the goal of VCLIC. And we are funded a little bit by Vanderbilt, and then we have some grants, and we mostly have a lot of engaged members who sort of volunteer their time and effort to make this better. And so VCLIC leads a bunch of programs and initiatives. We have a Grand Round series just like this one. In the last few weeks, we've had somebody come and talk about Epic Cosmos, and we did our clinical informatics update where we had our CMIO and some others come and talk about interesting projects they're doing. Our faculty in VCLIC teach a course, BMIF 7340, which is our introduction to clinical informatics course. We spend some time in the classroom learning stuff. We spend a lot of time in the hospital visiting the ICU and outpatient clinics and pharmacy and lab. And we recently visited the data center, which is fun to see all the big servers with flashing lights and stuff like that. We try to spend a fair amount of time in the hospital, sort of watching stuff and talking to users and learning as much as we can. In the last year, we started a new program we call VClips, or Vanderbilt Clinical Informatics Practical Shorts. These are short videos. Here's one that I wrote that is actually a little bit based on the talk I'm giving you guys right now, but it's basically a history of the electronic health record at Vanderbilt and sort of how we got here. And so I sit in my office and make these videos, and we've now made I guess 10 or 12 of these videos. We got 5 more that we're working on. But if people want to learn about Epic build capabilities, or signal data, which is Epic's kind of like logging data, or how to do geocoding, or how to get your exempt data only protocol from using secondary use of EHR data through the IRB, you can watch a little video and we'll sort of teach you about that. These have been surprisingly useful. We often used to either give in-person workshops about these, or people would come to my office and say, like, hey, Adam, how do I get data? And so now what we can do, I think it's a little bit more useful to say, like, hey, watch this video about data resources at VUMC, and then we'll meet. And then when we have the meeting, suddenly you have a lot more background, and we can actually get into kind of the meat of what your data request is and what you need, and try to help you more as we do that. So VClips have been pretty useful. I already told you guys about the Physician Builder program, but basically we have 88 physician builders at Vanderbilt. The 2 things we really require are you complete training from Epic, and you can do that training either in person in Verona, Wisconsin, where I think you'll learn more, or you could do it virtually, which would reduce the cost of the training. If you're a physician, there's actually no cost for the training. If you're not a physician, they do charge you something for the training. The second thing that you need is sponsorship from your department chair. Your department chair needs to say that he or she will allow you to spend some time, and we try to say 0.1 or 0.2 FTE to participate in this program. And we've got 88 people so far. About half of them build a good amount of stuff. Some of them don't build anything, but what I've noticed is that they are much better users of the EHR, and especially sort of requesters of things. So if you're trained as a builder and you need to make a request to VCLIC or Health IT for a new feature or a new build or something like that, you're often much better at doing that for having completed the builder program. So my goal would be that they'd all be building, but right now about half of them are building, and some of them are building a tremendous amount of stuff. That is for making new things like order sets, best practice advisories, pop-ups, the displays of information in Epic, and we realized that there was a parallel need for data access. And so we created something called VDOGS. I did not know this acronym. My colleague from anesthesia, John Wanderer, did. It's the Vanderbilt Database Access Working Group. But basically, if you do, again, some Epic training and then get sponsorship from your department chair and agree to let us audit your queries and do a privacy training, we will give you access to Clarity and Caboodle, which are our two main Epic provided data warehouses, and that lets you do a lot of sort of self-service analytics and data. We had 24 people do that. I at one point told people that there's probably a total market size of 6 to 10 faculty that would be willing to do this training, and I was wrong. I think we'll probably eventually get up to 50, but people are willing to do the training in order to get access to data. And I actually think that people, just between us, who have the ability to build stuff in the EHR, get their own data out of the EHR to design and then study the things that they do, and then some domain knowledge, whether that's clinical knowledge or informatics knowledge, are going to rule the world, right? Like the cycle time becomes so short if you can get your own data, build and release your own intervention, study it, look at its impact on clinical practice, and just kind of keep going. So not surprise, I guess it was a surprise to me, it shouldn't have been. A large number of the VDOGs are also physician builders, so people decided they want to participate in both programs. On the flip side, there are several thousand faculty at Vanderbilt, and they don't all want to go to Madison, Wisconsin for a couple of weeks to complete these trainings. And so some of them just want to hire somebody to do this work. And so we have what we call the Clinical Informatics Core, which is a fee for service thing. So your hospital has cores that do things like genotyping and microscopy and stuff like that. And we realize, and core is basically an NIH concept where you come up with an hourly rate. Ours is $140 an hour, and you provide services to people. And so in our case, rather than providing mouse colony feeding, we provide clinical informatics services, primarily clinical data extraction, analysis, and the design and build of interventions in the electronic health record. And we have had the core for a couple of years now, and we've had 224 requests. We've completed a goodly number of them, almost half, and we're sort of working through the rest of them. But the goal here basically is that everybody who needs something done, and something is usually either data or build in the EHR, can either service it themselves using our self-service programs, or they can use this managed service called the Clinical Informatics Core. And so that I think has met the needs largely of people in the field. So those are some of the services that we provide. We also partner closely with our operational health IT group. It's worth saying that at Vanderbilt, historically, the Department of Biomedical Informatics and the operational health IT group were the same group. At the time of Epic, they did sort of split, but we actually had the same person was both the DBMI chair and the CIO of the hospital. Since then, they're now two separate people, but we work very, very closely. And so VCLIC works with Health IT to do evaluation and dissemination of the cool work that Health IT is doing. And so if I'm sitting, I was in a meeting last night and somebody was talking about a new tool they built to improve the experience of colonoscopy prep. That's an unpleasant experience, but we'd like to make it as painless and effective as possible for patients. And so we showed that there was about a 1/3 reduction in the number of patients that had kind of poor preps for their colonoscopy. And that was just something we did for operations because GI asked this too. And so I said, well, let's write a paper about that. Can we sort of analyze this a little bit more formally and write something for JAMIA or for a GI journal? And so that is our evaluation and dissemination program. Our health IT staff don't always have the same incentives that people like us do to write papers or get grants or give presentations at conferences, but they tend to be willing to do it or open to doing it as long as somebody's willing to do a lot of the work, like getting the data and sort of analyzing it. So we do that. We call it the Evaluation Dissemination Program. It's been a really fun partnership. These are more minor things that we have a monthly newsletter where we tell people sort of what's going on in clinical informatics at Vanderbilt. We have a wiki knowledge base on Confluence. So if you want to know, how do I get access to Epic or Clarity? How do I build a Fire application and running in our in our sandbox? How do I improve or write a new best practice advisory? You can find some articles and help and people to reach out to through our community and sort of written down in this knowledge base. This is also where the VCLIC videos originally lived, and then we now put them on the web too, but that's where they sort of initially were. We offer some education, so we offer a residency elective for residents. We offer another elective for medical students that are interested in informatics. We have an informatics fellowship program. We have a couple of degree programs, but we think that it's very important that we are providing education and training to these people. I guess I have a few minutes. I'll sneak in one other quick program that we've run here that I thought was a lot of fun. We called it Clickbusters, and it was inspired sort of by the Adopt a Highway programs. You can see here, I imagine you guys have this in Alabama too, but in Tennessee, you can adopt a stretch of highway and you don't clean it yourself, but you like pay somebody to clean it and keep it nice and stuff like that. And so we created a program where clinicians or informaticians could adopt a best practice advisor. Those are those pop-up alerts that sort of show up in Epic. People signed up for the program. It was a little bit gamified, so you would earn points, and we had fabulous prizes, and people would follow a 10-step process that we came up with. It's shown right here to bust, we call it click busters. So to sort of bust some clicks and reduce the number of alert firings, the number of clicks in the EHR. And so, the steps were what you might imagine, to kind of look at the alert and try to understand its current function, review some data, talk to some users, look at the clinical evidence, make some changes, release them, evaluate them, and share the results. And so people engaged in more ways than I had imagined. We gave away some trophies and Amazon gift cards and certificates. I found a company that was most famous for selling a hot dog shaped trophy and convinced them to make me a golden computer mouse trophy. And they actually tell me now that this is one of their best sellers, but basically it looks like a mouse and you get it for busting clicks. And so for the cost of a handful of trophies, we managed to get a couple dozen people to participate in the program. You can see some of the winners here. In the first round, we had a 10% reduction in the number of best practice alerts or advisories that are firing in our Epic EHR. In the second round, we had another about 5% reduction. And besides the direct benefit to users of reducing the number of clicks in the EHR, we also managed to create a community of people here. I see somebody from primary care, somebody from the emergency department, another primary care, anesthesia, gastroenterology, pediatrics, psychiatry, pharmacy, anesthesia again, geriatrics. So I'm just looking across this informatics, this set of people, we've ENT, man, there's a lot of people here. We've been able to drastically reduce the number of alerts that are firing and build a community of people that now I hit up constantly. So if I have a question, if I'm trying to do something in the NICU, I send a note to Lindsay and say, hey, Lindsay, what do you think about this new idea we have for retinopathy of prematurity screening or something? So it's been tremendously helpful to sort of build and grow this community. So that is what I wanted to tell you guys about. I would love to answer any questions. I would encourage you guys to play around as much as you can with your EHR and sort of learn about it and figure out how to use the data and the system in your research. And I would also love, if it comes up, to think about ways that we could think together. So I'm going to pause here. I see a question from Dr. Reddy about the pathology module in Epic called Beaker. And so we are in the process of implementing Beaker. So Epic has many modules, as you guys probably know, and they all have cute names. So the labor delivery module is called Stork. The radiology module, which we do use, is called Radiant, and their laboratory system is called Beaker. And so we currently use Cerner as our laboratory system. And what I would say about Epic is that they tend not to be bad at anything for very long. And so Epic initially did not have a lab system. They said you should use an external third-party lab system. Then they built this system called Beaker, and it wasn't very good. And then they worked on it over a few years with their customers, and now it's supposed to be quite good. And so we are in the process of implementing it. We're pretty excited about it. There are pros and cons, right? So Cerner or SunQuest or some of these systems are made kind of only for laboratory professionals. This is made, obviously it's now a module within Epic. And so that has the advantage for the lab that they would then be working in the same system as the user. There's fewer interfaces for orders to come into the lab and then results to go out of the lab back into the EHR. We've run into situations where, everything looks totally, the result looks totally good and normal in Cerner, and it looks really wonky in Epic. And now that won't happen because, it looks the same in Beaker as it will look in Cerner. We kind of need to set up how the result works. We have heard from our colleagues that many workflows are as good or better in Beaker. Some workflows, for example, around microbiology, may be less good right now, but they're in the process of improving them. And Dr. Wright had a specific question about the blood bank software. And so Jennifer Andrews is our blood bank director, and she's actually a member of the Informatics Center here. And we use iSoft as our blood bank software. The FDA historically has stayed out of regulating most EHR capabilities, and they're getting more interested. But historically, one of the capabilities that they have regulated has been blood bank software. And when the FDA started regulating blood bank software, there were like a dozen vendors of blood bank systems. A lot of them went out of business the same day that the FDA announced they were going to more fully regulate them. And so there's a handful of these people that sort of go through the FDA process. As far as I am aware, Epic does not have a blood bank system. And so I believe that we'll continue to use iSoft in our blood bank and use Beaker for the rest of our laboratory work. But I can't fully answer your question because we're not using Beaker yet, but I think we're optimistic about the Beaker conversion. It's a funny time for our lab because our lab was on site in the hospital and just moved like 4 miles away from the hospital to this huge facility. And now we sort of drive the samples over on a truck and stuff like that. And so they just got done with that 2 weekends ago, and everybody's like, oh. And then now we're implementing Beaker. And so we're currently in this sort of refractory period where people are kind of recharging from the move before we switch to the Beaker implementations. So, Dr. Reddy, I'll have more opinions soon.
I have a follow-up question if I can.
Of course.
Hi. Thank you for the answer on the two items I raised. One of the things your previous software, if I'm not mistaken, had a live I would say real-time dashboard in pathology for the populating the tests as they come up as they come out. For example, cytogenetics or the molecular testing, they have a dashboard which is populated automatically. That means the clinicians and the pathologists would have a view of that. You have anything planned for in the Beaker?
My understanding is that we'll have the same sorts of dashboards when we're using Beaker. I don't know whether that's a built-in capability or an add-on that we're creating. But I think, like anything, Beaker has APIs, and so you can kind of create and pull these work lists and show them. We always try to build it in Epic when we can, but my understanding is the lab will continue to have those same dashboards.
Thank you.
Yeah, absolutely. And I'll also just sort of flip the question around a tiny bit. And one of the things we're excited about is, I order blood, and then, there's sort of a series of steps, and a popular thing to do is to call the blood bank and say, where's my blood? Where's my blood? And so now you'll actually, it's almost like if you've ever ordered a pizza on Domino's.com or Papa John's, it sort of shows you like we're, making the pizza, it's in the oven, it's going to the driver, it's on the way to your house or something. So the ordering provider will actually be able to see in more detail the status of their blood order to sort of know where it is and that someone's actually working on it and the blood's going to come soon. So that's the hope, is that tighter integration will give better visibility to users.
Yeah, the reason I asked about the blood bank, we have a very active blood bank system here,
Yeah,
and we are one of the major trauma center here in the
right.
Birmingham area, and so that is a critical item for the. I think right now they have a Cerner, they have a Cerner system in the
Right.
blood bank, or some kind of variant of that. Okay, that's the reason. Thank you so much.
Yeah, absolutely. And Dr. Reddy, I dropped a link to Dr. Andrews, who's our blood bank director, and she's a big informatics person and very interested in this. So
Sure,
I don't know
sure.
if you've met her, but I bet we could come up with some good collaborations between UAB and Vanderbilt in the sort of blood bank automation and
Sure,
operation
by all
space.
means, yeah.
So, yeah, she's terrific. She's a physician builder and a wonderful human. So
Thank you.
yeah, thanks, Dr. Reddy. Any other questions out there?
Hi, it's Amy Wong. Thanks for the wonderful presentation. It's also always great to get the historical perspective and kind of like what it was like before EHRs. And
Yeah.
that is interesting that you did it all on your own, and then you get criticism for that because that you're doing your own thing. And
Yeah,
like, what about
exactly.
us other common people? But I want a golden mouse trophy.
Absolutely.
So
Run Clickbusters at UAB.
I'm just wondering what's the balance? Like, you were so used to having everything built yourself, and I know from experience that Epic won't build something unless unless it's really important or a lot of people want it because it touches everything and it's such a big deal. So I know that I see you're building some things on your own in the modules that in the areas that Epic allows for customization. So what is your like? So you created this really great thing. Now, is that only going to be at Vanderbilt, or how will that get to the rest of the community? Are you able to share things, or
Yeah.
you're able to say, hey, look, Epic, look, everybody loves this. This works so well. It would make your
Yeah.
product better. Why don't you do this? So what's the balance between,
Yeah.
put yourself versus the community and
Yeah,
Epic?
let me answer your question from a couple different angles. And so there are, obviously you get Epic. Epic is largely unconfigured and you have a lot of customizability. There's probably 4 levels of customization that we do. So the first one is what I would just call build. So that's, as a physician builder, you go in, you configure a new BPA or smart set or documentation template or something. Epic totally supports that, is in favor of that. They'll train you how to do it. And that stuff is easily shared. And so Epic has a community library. If you've never seen it, it's comlib.epic.com. And they actually have this job that basically kind of goes out and vacuums up all of my order sets and all of your order sets and puts them there so other Epic customers can see and use your build. And so when I'm going to build something new, like I was just trying to build the H. pylori eradication template and their order set. And so I looked to see how other people had built it on the community library and got some ideas from that. So that's what I would call build. The next level would be sort of this sort of custom programming that we can do. And so Epic has these things, they call them programming points or extensions, where you can write like a brief chunk of mumps or im or cache code that runs in the system and lets you do a more advanced calculation or figure something out in a way that you can't just do in Epic's drag and drop GUI build tools or something like that. And Epic also supports custom code, and they have courses that teach you how to do it. We do a fair amount of that and share that. You can get into a situation where if you have a ton of custom code, then things like break when you do an upgrade sometimes. And so you have to be a little bit cognizant of that and make sure to check things when you do upgrades and test them well. But if you have some good test scripts and change management procedures, you can usually sort of work your way around that. The third one is sort of hooking into Epic externally using APIs. Since we have a lot of visualizations and dashboards like the kind that Dr. Reddy was talking about that are sort of built outside of Epic. Again, if we use either the sort of open APIs like Smart on Fire or Epic's proprietary APIs, there's pretty good policy for sort of creating those and deprecating those and sort of tracking them and maintaining them, versioning them over time. So that works. And then the fourth one, which I think part of what you're alluding to, is true custom development, where you actually have to go to Epic and say, hey, we think that the way you order, tapers is really confusing. Can you just fully change the way that tapers are ordered, not just for us, but all Epic customers? And that probably has the most latency. If you make a request like that, Epic takes it down one of two pathways. If they decide that all Epic customers would benefit from it, they'll just do it. And there probably the job is almost sort of like brigading, right? I call my friends at UAB and Duke and say like, hey, let's all put this request in together and I really like show Epic we want it or something. The other one is what they call custom development. You pay them like money and they build a feature only for you, and they really hate doing that and they resist doing that. So in terms of dissemination of these things, I used to build these things and would present them at AMIA, and maybe like one person would call me on the phone and say like, hey, I like your naloxone thing, tell me how you built it. I built one myself. Often when I give a presentation at UGM or XGM, which are Epic's meetings, of something like the naloxone thing, I come home and I've got 24 messages from hospitals across the country saying, we want to implement that thing. And they can sort of go on the community library and download parts of it. Often we have to give them some coaching, because usually we didn't just build a BPA, we also like did some training, and we sent out an email, and we had somebody run a report and make sure people were following it or something like that. So we usually try to meet with these people and explain what we did and stuff like that. But I've been shocked at the impact that we've been able to have on other Epic customers. The last thing I want to mention is Epic has something they call the foundation system. They call it the model system, where if you have good content, they actually sort of build it into the default out-of-the-box package that other Epic customers get when they first go live on Epic. So a lot of the things, not a lot, dozens of the things that we've built, Epic has moved into the foundation system. So new Epic customers have gotten them. There used to be this gap where if you were an existing Epic customer, you didn't get them, but Epic now has something they call it turbochargers. Like I said, everything Epic has a cute name, where you can take things that are added to the foundation system after you go live from other Epic customers and sort of backload them into your system. And so we've released a good number of the things that we have made as turbocharger packages for other Epic customers to use. So again, if you're willing to sort of like drink Judy Faulkner's Kool-Aid and like kind of play the Epic game, I think you actually do quite a bit of dissemination to other Epic customers through that.
Yeah, well, thanks. You're such an incredible resource that you know how they work, the organization and customization, that you're able to, you're sort of able to also support other Epic customers. They should be paying you actually to you're helping them.
I wish. I wish.
Yeah, well, we're at time, so
Yeah.
I don't know if you're able to hang around if you have any more questions.
Absolutely.
Definitely don't want to feel like people have to go, but if anybody has any questions, feel free to put them in the chat or unmute yourself.
Yeah. And there's my email. You guys can email me anytime. Come visit us at Nashville. I'll come see you guys. I would love if an outcome of this talk was at least 1 or 2 new collaborations between our centers.
Now Epic predates you there, right?
It does, yes. So I went through the Epic transition when I was at Partners. And so Partners had exactly the same situation where we were using the LMR and BICS and stuff. I was there for that Epic transition, and then I arrived shortly after Vanderbilt had switched from the old systems to Epic.
Oh wow! So you're a battle-scarred veteran.
A little bit. Well, what happened was I showed up and everybody was all grumbly. They're like, "Oh, I used to really get Dario to do this stuff for me," and I was like, "I really think Epic can do that." And so that's why we created VCLIC, was basically to sort of help people see how they could achieve the same levels of access and integration and innovation in Epic that they had previously experienced with our self-developed systems.
All right. Any final questions, comments? You can always contact Dr. Wright at Vanderbilt. Well, if not, then thank you so much for the wonderful presentation. I hope to see everybody at future presentations, and I hope everybody has a great weekend.
Awesome. Thanks, Dr. Wong. Thanks, everybody. I really appreciate it.
Thanks so much. Bye-bye.
It's a lot of fun. Bye.